For this literature review, we are looking at a paper published in Gastrointestinal Endoscopy in November 2022, which was entitled Intraductal, Fully Covered, Self-Expandable Metal Stents versus Multiple Plastic Stents for the treatment of biliary anastomotic strictures after liver transplantation. The lead author for this paper is our good friend Janine van Hoeft, who we're delighted is going to join us for ESGE Days in London on the 21st of April. We look forward to seeing you there. Now, biliary anastomotic strictures are one of the most common adverse events following liver transplantation, and the ESG guidelines suggest that multiple plastic stents should be placed at 3 monthly intervals, with multiple plastic stents increasing in number each time for 1 year in order to ensure that you expand the stricture and maintain patency. Now, whilst this is effective, of course what it means is the patient has to endure multiple procedures, which are costly from a resource point of view, but also of course increasingly expose the patients to the potential complications of ERCP. So, to combat this issue, an intraductal fully covered self-expanding metal stent was developed by Taweoong, and it aims to prevent stent migration and pancreatitis due to its shorter length and complete intraductal insertion. It can easily be removed using an extraction string. This paper reports on a study to determine the performance of this new stent versus the multiple plastic stents in the context of anastomotic strictures post-liver transplant. In this study, for the metal stent group, the minimal stricture distance to the biliary confluence had to be approximately 2 centimeters, and the body of the stent resided completely within the bile duct, with the extraction string coming through the papilla into the duodenum. 6 months after this stent was placed, the patient was brought back for an ERCP to then remove the stent. In the multiple plastic stent group, 1 or more 10 French plastic stents were placed in the bile ducts, and they were placed across the stricture, with further procedures performed every 6 to 12 weeks, where the stents were removed, the stricture was dilated using a balloon, and then an increasing number of plastic stents were inserted. For this trial, 80 patients were included, 44 of whom received the metal stent and 36 had the multiple plastic stent approach. Now, the results of this study were very encouraging. They demonstrated that there was no statistical difference in stricture resolution, with both groups achieving high resolution rates. The metal stent group achieved 93% resolution, and the multiple plastic stent group achieved 97% stent resolution. The median time to resolution of the stricture was 19 weeks in the metal stent group and 26 weeks in the multiple plastic stent group. The metal stent group required, of course, only 2 ERCPs, and that's compared to 4 ERCPs for the plastic stent group. Importantly also, the recurrence rates were similar, with the recurrence of the stricture occurring in 33% of the metal stent group and 29% of the plastic stent group. The adverse events in both groups were comparable and low. So what does this data tell us? Well, it tells us actually that these new intraductal fully covered metal stents are equally as effective and safe as the multiple plastic stent approach. And this effectiveness includes both initial stricture resolution and also long-term outcomes in terms of recurrence. Importantly, of course, it addresses the issue of the burden of the multiple plastic stent approach, where patients are now having to come for less ERCPs, which of course means patients are exposed to less risks, and of course it takes less resources out of the healthcare. Another advantage of the intraductal metal stents is that the migration rate appears to be improved in these intraductal stents. The quoted migration rate in this study was 16% for the intraductal metal stents. Now, data on non-intraductal fully covered metal stents suggests that the migration rate may be up to 33%, and in the multiple plastic stent group, the migration rate may be up to 39%. And of course, in theory, we know that stent migration can lead to bacterial cholangitis caused by the risk of reduced flow. So potentially this is another advantage of these intraductal metal stents. So there's clearly more work that needs to be done, particularly looking at prospective studies looking at these intraductal fully covered metal stents versus the plastic stents. And of course, we also know that probably you need to look at longer treatment durations of over 6 months to properly compare this work. However, certainly this study demonstrates promising data that intraductal metal stents may well be effective in stricture resolution, preventing recurrences, and of course reducing that impact on both patients and healthcare resources. So I encourage you to read this paper and also watch some of the amazing footage we have from our various courses and within our knowledge centre on the treatment of biliary strictures. Enjoy.